Our next speaker is Dr. John Morton, professor at Stanford. John is also the co-chair of the joint ACS-ASMBS accreditation guidelines. So, John, we're interested in your three biggest errors.
Well, I want to thank both Dan and Raul for the opportunity to speak to you all today. I like the beard, Raul. I have no disclosures. This is a series of taxonomy of revisions. This is courtesy of Matt Brengman, who's our chair of the ASMBS Insurance Committee. This is just to demonstrate the wide variety of potential revisions, everything from the primary procedures to the clinical indication to the secondary procedures. Important to know because there's a lot of insurance issues that can come up regarding this. So if we look at the different procedures out there, they all carry some degree of complication that are unique to the procedure. Obviously, you've heard this morning a little bit about the bypass and the DS and the sleeve and the band, but all of those potential complications can lead to reoperation. Big ones when it comes to the bypass are around perforated ulcers and small bowel obstructions, which you guys have heard a little bit about already. Let's skip this. So here are three potential issues that can occur. One is with the gastric fistula when doing a bypass. This has occurred to me once where we thought we were around that division. A simple thing to do is obviously place some sort of retracting forceps underneath to fully expose that area, make sure that you're seeing that left cruce. Now the sleeve stenosis can occur with some degree of frequency. And a few things to consider there. One is to obviously have the either the bougie or the scope in place. For us, we like the scope because we can insufflate afterwards. We can maneuver it. We do it ourselves, not the anesthesiologist. But that being said, if you sometimes oversew, you can end up having stenosis in that area. A few things to consider. One is to wait, and perhaps it'll open up on its own. The other one is to dilate. Generally don't dilate until we're at least a month out. But the third thing to do is to convert to a bypass. And lastly, there is a description of incising some of the outer muscular wall, almost like you're doing a Heller in that area of stenosis. For the bypass stenosis, one thing to consider is who gets these. These tend to be ulcers or strictures. These tend to be in the larger patients. One thing to remember is to start dilating them sooner rather than later before that tissue becomes rock hard. And again, probably the earliest I would start is about a month in. A few things to consider in reoperative surgery. One is how often this occurs, the indications, and of course figuring out what you can and can't do. When I say avoid insanity, one of the definitions of insanity is doing the same thing over and over again, expecting a different result. And thanks. And I think you have to be careful in doing an operation where you didn't get good results to begin with, and then, excuse me, and then repeating that same procedure. The other thing is you've got to realize if you're going to actually do something to help this patient. So how accurate are we in assessing risk? Well, this is a study that came out a few years ago that looked at the ability of colorectal surgeons in this case to assess risk, and they found it was actually pretty poor. The ability to assess risk was as good as flipping a coin. Hopefully we'll get a little more accurate with that as time progresses. A few things to consider if you're entering into this idea of revisional or reoperative surgery. This is a study from labs that showed that there is a much higher morbidity rate associated with it. It's actually threefold. If you take a look at this individual study here that looked at gastric bypass, take a look at those risk factors for predicted complication. Number one on the list is revisional surgery. I have included those other three just so when you're deciding to reoperate on a patient, be wary of the patient who's increased their weight over time, older patients, and the male gender patient. Now, if you look here in terms of the weight loss according to the procedures, this is by Bob Brolin, who has one of the bigger experiences for reoperation. A few things to consider again is a high rate of morbidity and mortality, and this is a lot about setting expectations for that patient. So the most important decision you can do is not to operate. You have to really figure out if you're going to help this patient at the end of the day. And sometimes the decision not to operate can be the hardest one. The other thing I always like to say to our residents and fellows is just because you can doesn't mean you should. And you really should figure out if this is the right procedure for patients. If you look at one of the reasons for reoperation, it tends to be weight regain. This is from the SOS trial, and you can see that almost all the operations have a small measure of weight regain. If you look at it as well, there's also potential for some of those comorbidities to come back. So one of the reasons that we operate on patients is because of weight regain and comorbidity recurrence. One thing to always mention to your patient, if you are going to embark on redoing a certain procedure for weight loss, keep in mind it's never as good as the first time. And you can see here with this particular study that the best weight loss is with the primary procedure, so figuring out the first time is extremely important. If you look at what do you do with the bypass, one of the considerations has been to lengthen the limb. But if you can see here, in comparison short and long limb, this is 10-year data from Nick Christou, it didn't really make a difference. They were essentially equivalent. The other thing to keep in mind, if you're going to lengthen that limb for the bypass, that you are going to put yourself at a bit of risk around protein malnutrition. The other procedure that we all know has a potential for reoperation is obviously the gastric band, and this is data from Jacques Hempens that shows that you can have some results that are upward of 50% of those patients removing their bands, either because of technical issues or because of insufficient weight loss. How do you decide what to do with these patients? This is a pretty simple algorithm Dave Lautz and others have come up with. If the patient lost a good amount of weight in the beginning, that might be one you want to revise around the band regarding whatever issue it might be, prolapse, etc. If they never lost weight, you're probably better off going straight ahead to removing the band and converting. One of the issues around weight regain that's been mentioned quite a bit has been the gastric pouch size or the stoma size. You can see the ideal size is roughly about 30 centimeters, and the ideal stoma size is 12 to 15. There are different approaches, and there are this particular company, StomaFix, is now on hiatus, but there are other endoscopic approaches to reduce that pouch, and the idea is just to plicate it, to make it smaller, much like you make pleats in a skirt. This is our own data around the StomaFix. We did some patients who were pretty large to begin with and had some substantial weight regain, and we had some good results with them at roughly about a year and a half. But you can see there's variation. Again, the biggest thing in deciding to reoperate on somebody who's lost weight, they better have lost weight the first time. If they didn't, embark with caution. Now, one thing to consider with these patients, if you're going to reoperate on them for weight gain, make sure that they put a little sweat equity into the equation. Make sure that they put their money where their mouth is and they actually try to lose a little bit of weight. So for these reoperations for weight gain, I ask for a little weight loss in the beginning because it helps get us to their commitment. There's obviously OptiFast. There's also new drugs, if it fits. Qsymia is the one FDA-approved drug. And you can see some good results with it. This was the Geisinger data that saw these patients lost more weight at long term when they had some pre-op weight loss. And if you look at the risk factors, this is really interesting. Right, the second leading cause of complications, at least in this group, and it's a pretty large group, right after open procedure was weight gain. So again, be careful with these patients who gain weight before surgery. May not be committed to it. Can't always operate on their stomach and their head as well. One other thing to consider here is a randomized trial we did a few years ago where we saw people who lost more weight before surgery did better after surgery. And you can see with this systematic review, there's been pretty consistent reporting of data that shows that pre-op weight loss leads to better outcomes. I put this one slide up to show that the pre-op weight loss is important for a reason. Those big patients, BMIs greater than 50, don't lose as much weight proportionally. We have to do something in a kind of neoadjuvant manner to decrease their weight before surgery to give them a better outcome at the end of the day. Now this is the mini gastric bypass. I'll mention it super briefly, kind of have a big topic here, but the main complication with the mini bypass is biliary reflux. Simple conversion for this is to convert it to a full-fledged Roux-en-Y. I'll present this last case to close out. For some reason I get a lot of VBGs in my area, and this is a 59-year-old patient. She lost a good amount of weight. Check, that's a good thing. Now she was having some serious symptoms, 19-year history of GERD, unable to sleep, having emesis, so she was having some serious problems. We confirmed this. Always do your imaging ahead of time, important from a risk management standpoint. Upper GI showed an esophagus that wasn't working too well. So what do you do with these? The best thing is frankly to convert them to a Roux-en-Y. You have to work within the former staple line, but the results can actually be quite good. As you can see here, all the symptoms decrease substantially, and they also decrease their BMI at the same time. Here's what this lady's esophagus looked like before surgery. You can see that it's almost a pseudoachalasia, a very enlarged esophagus. It becomes tortuous. And you can see the very narrow outlet for the VBG. By converting it to a Roux-en-Y, which is what we did here, you can now see that the esophagus looks a heck of a lot more normal. So when you're going through the idea about doing revisional surgery, figure this out in terms of a checklist. Is it a surgical problem, or is this a psychological one? Is this one where they haven't gotten enough education? Secondly, can it really be fixed? Are you the right person to do it? What's the risk involved? Correct procedure, resources, timing. And finally, if there's a complication, can this patient survive it? These are all things that should be going through your mind. As I demonstrated earlier, the risk involved with reoperative surgery are much higher, so you need to embark with caution. So in conclusion, first, do no harm, avoid insanity. Don't do the same thing over and over again expecting the same result. This is the happiness equation, reality divided by expectations. Set your expectations appropriately. And at the end of the day, we know obesity is a chronic disease, and we will have to deal with a lot of these revisions. So thank you very much. Appreciate it.
Thank you.